Good to see everybody. Dr. Joe Thompson's with us, and everybody knows him, I think, on the call, but he's, he is one of the best, and he's got a great team of 40 people helping him, and we're grateful to get the opportunity to learn from him on occasion. We look forward to this morning. So, Dr. Joe, take it away.
There. Can you hear me okay?
Yes, sir.
Okay, great. Thank you for having me. Michael Farrell is going to be helping me today run through here. I just want to start off by saying this is going to be a little bit of a sobering presentation. We do have some light at the end of the tunnel with our vaccines, but we've got some pretty dark months coming, and we're starting to see some of those impacts. I put this first graphic up because at least here in Central Arkansas, we had our first frost last week, and all my summer plants are now bending to the will of the winter, and kind of like the TV show Games of Thrones, winter is coming, so we got to get ready for it, and it is going to be, I think, a challenge. We are seeing, and I just want to be explicitly, we are seeing higher numbers in Arkansas than we have seen before, and we are on a trajectory with an accelerated rate that puts many of our communities, if not all of our communities, in jeopardy and puts families at risk in a way that they've never had before. We had the most admissions for hospitalizations in one day back a month ago, but we have the highest volume in hospitals each day as we speak. And we had the highest number of new cases this week. We have the largest number of active cases this week. We had the most deaths reported yesterday. Every one of these indicators is going in the wrong direction. And I think, like the tropical plants on the previous page, if you listen to some of the national public health experts, they are, I think, significantly concerned that the next 2 to 3 months before we get into the spring where people can get back outside, before we have the vaccine more widely available, that we are in trouble. I think the next graphic kind of shows this. This is, we've shown this before. The thing that's changed is before the vertical axis over on the left side only went up to 80,000. Now the vertical axis is up to 200,000. The United States is having 200,000 plus new cases confirmed every day. The other lines here are the other developed countries. You'll remember we in India, which has 5 times the number of people, were vying for that top spot. I mean, India now has less than 50,000 new cases a day. We have over 200,000 cases a day newly diagnosed. All of the United States, with the exception of Hawaii, is experiencing uncontrolled spread. The positivity rate in our state is around 17% now. That's 17% of every test taken is newly positive. This is across the entire state as well as the entire nation. On the United States, we're now, as I mentioned, we're having 200,000 new cases a day. We'll cross 15 million cases today. We've had over 20,000 deaths just in the last 7 days in the United States. So this is, I think this is a sign of our loss of control here. I think we all want to believe that this invisible threat is not gaining on us, but in reality, it is overwhelming us. And I'll just put strong messaging out there now. If you're over age 65, or if you have comorbid conditions, it's time for you to eliminate all unnecessary activity and to consider sheltering in place. This is across all of our communities, yours in Northwest Arkansas specifically. So when we track this and we see it, we've been doing school trends over the course of since July. And if we can go, Michael, to the first of these, you'll remember, this is the number of new cases over the past 2 weeks per 10,000 residents. And we started off with a few red and a few purple, but most of all the state was green. And you'll see here, just in the last 4 months, we did pretty well in August as we masked up and everybody started, controlling things. We went back to school and we were doing pretty well. We started going inside. We started losing it a little bit. We hit Halloween. And, we've just lost control of this virus now with, a majority of the state in the red zone now on school districts. I will say, as released yesterday, your 3 school districts in Northwest Arkansas in the schools themselves have the most active infections of any school district in the state. Springdale, Rogers, and Bentonville school districts are the top 3 school districts with active infections in those schools from personnel and students in the state. The numbers for Arkansas don't portend well. Again, we mentioned these numbers before. We've got over 1,000 folks in the hospital now, approaching 200 on ventilators, 2,700 deaths. You'll see on the next slide the number of new cases. And again, this is the days that are lower. Those are usually Monday and Tuesday because we didn't test people on Saturday and Sunday. But it comes roaring back in the middle part of the week. I think today's numbers probably will not reflect the numbers that we saw later this week. We had 2,700 new cases diagnosed last Saturday. I think that's probably we'll cross 3,000 new cases a day sometime this week. And again, this is the Halloween surge, and now 10 days after the Thanksgiving get-togethers that occurred, we're going to start seeing the Thanksgiving surge on top of the Halloween surge. When we look at hospitalizations, we're seeing those grow again in the 45 to 64-year-old age range being the most frequent, and the deaths obviously in the older population, but starting to creep down into the younger population. When we look by trauma region, you'll remember when we were looking at active cases per 1,000 residents and we were in the 1s or 2s. We've now got every trauma region broaching 5. The northeastern part 7 per 1,000. If they get to 10 per 1,000 in that trauma region, that means that more than 1% of their geographic population has been newly infected in the last 10 days. You're at 0.5% have been newly infected in the last 10 days in Northwest Arkansas. And of course, these numbers continue to grow on our trend lines. Unfortunately, they're going in the wrong direction. This is directly, active cases, new cases are an early indicator. A certain proportion of those individuals are going to get sick. And then from that, hospitalizations, and unfortunately, some folks will succumb to the illness. We are seeing in our hospitals just a dramatic increase. I've talked to 5 of the major CEOs, including yours in Northwest Arkansas over the last 3 days. They are at capacity. They have not yet had to eliminate elective surgeries. That is the next step. And elective surgeries are not necessarily non-needed. We have folks with heart valve problems and atherosclerotic disease that are having mild chest pain, other things that are quote elective, non-emergent. That's what would be on the ceasing next, because if they don't have the ICU capacity, they can't do those elective surgeries that require a period of time of both staffing and capacity after those. So I would encourage you to watch for that as the next warning signal on our hospitals, that they start ceasing to do elective surgeries because of the burden. When we look at, on the next slide, the new hospitalizations and ventilator numbers, again, there's a little bit of a fall off on the past 3 or 4 days. That's largely because reporting hasn't come in. If you look a week ago, you'll see we had some of the record highs of number of new hospitalizations and individuals on a ventilator in the last week or 10 days. We still have the comorbid conditions that we're tracking, and again, the steroid use, cancer therapy, immunocompromised individuals, individuals with kidney problems, heart disease, diabetes. These haven't changed much. They're just getting more and more solid, that these are conditions, regardless of age, that are associated with higher hospitalization, ICU admission, and bad outcomes. When we look at new reported deaths, we are stepping up here with 53 yesterday. We've had 100 new deaths just in the last 3 days reported across the state of Arkansas, and so our 100 death count watch on the next slide is significantly accelerating, and I fear is going to continue to move faster. These are not just about 40% of the deaths, I think, are reported to have come from individuals that were institutionalized in a nursing home or others. So 60% of these deaths were people that were living at home, leading normal lives, may have had a chronic condition under control, but the virus, unfortunately, has attacked them. On the next slide, this just is a graphic demonstration of the blue line is the average number of deaths per day for the last 5 years before 2020. And the red line are the deaths per day in 2020. And you can see that, before March, we were tracking them about the same, April about the same, but then as the virus spread started increasing, the number of new deaths started increasing. And at least to date, we have had about 3,500 excess deaths compared to what we would normally expect. So with 2,700 of those attributed to COVID, we got several hundred that are probably either partially attributed to COVID directly, or it's people that are having chest pain, having early signs of a stroke that are not seeking care because of their fear of engaging with the healthcare system. So just on this slide, I think an important message is if you're having chest pain, if you're having jaw pain, if you're having, speech problems, facial weakness, those are medical emergencies. Pick up the phone, dial 911. Don't be afraid to go in. On the other hand, we need to do everything we can to avoid contracting COVID-19 and having the virus take its effect. We do have a few new treatments that are in the line. Again, we're tracking kind of the treatment options. We've got 2 or 3 that have been approved or widely used. We've got some in the pipeline. None of these do I see as a knockout drug. I don't see any of these as something that if you get COVID, it reduces your likelihood for a bad outcome by more than 5 to 10%. So these are tools that our clinical workforce has, but they are not knockout solutions. The goal here, your goal should be to not come down with the virus itself. On these treatments, we've got a few, there are some treatments now for mild to moderate illnesses. These are the IV antibody cocktails that have been created in our pharmaceutical industry that you can actually, if you're early and you're having, a deteriorating situation in an emergency room or outpatient clinic at a hospital, you can get an IV infusion to try to hold off the worst outcomes. Its attempt is to prevent hospitalization. It got emergency use authorization, these 2 did, by the FDA late last month. For hospitalized patients, we still have remdesivir. Again, that only reduces your mortality likelihood by about 10%. They've added another immunomodulator. I can't say the name, baricitinib. Again, I think they just have a Scrabble box that they throw letters out to see what they can make on these drug names. Dexamethasone is probably our strongest arrow right now as people's immune systems get revved up. And again, we continue to have human donation of convalescent plasma. Right now, remdesivir is the only FDA approved treatment. All of these are under emergency use authorization, meaning that they may help and that the emergency requires making their availability, but the proof is not completely cooked on these yet. On the vaccine update, we've still got a lot in phase 1, 2, and 3. We have some limited use or early use in case people are still enrolling in the US-based trials in the Baptist Health System or in the UMS system. If we go to those, we've got some preliminary efficacy reported, and the Pfizer vaccine, I think, will get approved for emergency use this week. Probably Moderna. Michael can go to the next slide. Moderna on the will follow about a week later. Both of these in the trials have had high levels of efficacy. Efficacy is how good it is under perfect situations. The effectiveness is what it is under real life situations. Those are always a little less. AstraZeneca, which is promising, but had some data quality issues, I think will not be approved in the United States until after the first of the year, if not into the next year. The Food and Drug Administration is going to require them to continue doing data collection without the data errors that were discovered. So I think we have Pfizer and Moderna. Again, continue to watch the development of these vaccines with three important questions, kind of the effectiveness, how good is it in real life, how safe is it? These appear so far to be safe. That's what the Food and Drug Administration is reviewing now on the Pfizer drug, and then the duration of immunity. There could be a fourth question here to be added, which is how difficulty is the distribution, and maybe even a fifth, how much uptake are we going to have? The Pfizer vaccine has to be stored at a minus 90 degrees Fahrenheit up until 6 hours before it's used. So it has some real restrictions on how widely it can be distributed and what the conditions are that it has to be managed. The Moderna vaccine just requires regular refrigeration, so I think it will be more widely available in probably non-hospital settings nationwide. On the next slide, the Committee on Immunization Practices, a committee that Dr. Romero is the chair of, did make a recommendation for how the vaccine should be implemented. That first, it should be offered to healthcare personnel on the front line and residents of long-term care facilities. Now, this is a little bit of an interesting structure. There are three players here. The Food and Drug Administration will actually approve the use of the vaccine. The Committee on Immunization Practices recommends how it should be distributed. And then the states are responsible for the actual distribution and immunization of individuals. So the immunization practices is recommended healthcare personnel, long-term care facilities get it first. We're waiting on the Food and Drug Administration, and I think the state will probably closely follow the Committee on Immunization Practices, although you may hear across the nation variations in this because it is state-determined implementation. In our state, well, the ACIP working group on the next slide had kind of three phases. In the first phase, healthcare personnel, long-term care or nursing home residents, essential workers in phase 1B, and then in phase 1C, individuals with high-risk medical conditions. The health departments, Arkansas Health Department's vaccination plan largely mirrors at least the first phases here. On the next slide, you'll see phase 1A is it's healthcare workers in high-risk settings. People in nursing homes. They're going to distribute the vaccine to hospitals based on staff risk and total cases. So for example, Children's Hospital, which is a large hospital, is probably not going to get many vaccines because kids didn't have the most severe illness. They're going to try to have at least one pharmacy in each county to be able to achieve this. We will have a restricted number of vaccines. We're only going to get 20 or 25,000 vaccines, and we probably have somewhere over 100,000 healthcare workers, nursing home residents, and others that will be in this phase 1A. So we are by definition going to restrict who gets the vaccine and will not be able to serve everyone who is in this phase 1A effort. This hopefully after the FDA approval and with the ACIP recommendations could start as early as this week if the FDA offered those approvals. Phase 1B on the next slide takes it to essential workers. These would be school employees that are in school, daycare staff, grocery workers, meat packing, jail staff, our essential workers. This would be the first 2 months of the next calendar year if everything goes as planned. Now, we are not guaranteed and don't have a number of vaccines that have been allocated to the state yet. So the 25,000 is of the Pfizer vaccine. That allocation has been, the trigger has been pulled on that. The approval we're waiting on. The number of vaccines for this phase 1B is unknown at present. And then phase 1C, which would be later, February to March timeline, these are people at high risk for severe diseases. The high risk medical conditions we mentioned, those age 65 and older, individuals with dementia, people in jails, and those that are living in congregate settings or crowded settings. But you'll see this still gets to probably less than 10% of the Arkansas population by March. So maybe 10 to 20% if we're lucky. So this is a real challenge. And I want to just emphasize, this is why the efforts that we have, particularly since we are seeing the spread that we have, I don't believe that I am overstating it when I say we need to actually go back to essential travel, essential interaction only. If you are doing anything that is not absolutely required for your daily activities, you are placing yourself and your family at risk of contracting COVID, and for anyone who has one of these conditions, potential bad outcomes, including death. The vaccine is a strong tool. It's almost like, and there was a study published, unfortunately, it's almost going to be like you suddenly have a hose in the middle of a forest fire. You're not going to be able to put the forest fire out with the vaccine. The vaccine will affect what our lives are like next fall and the next holiday season. But until next summer, we're going to be reliant on distancing, facial masks, and unfortunately, I think restricted movement so that we diminish the transmission of this virus. We're starting to see, and I just want to reemphasize, it's not just the acute infection, but we're really starting to see some of the long-term impacts. And on the next slide, I bring this back up. 2 months after individuals had gotten over the infection, over 75% had structural heart damage and ongoing myocarditis of some type. Those were in adults. In the autopsy study, we had 41% had the heart being infected. And then even in college students, 15% of college students who had been basically asymptomatically infected, but studied 2 months after, 15% had ongoing signs of inflammation in their heart, and 30% had strain. Now, one good piece of news is on the quarantine front, and I want to differentiate isolation from quarantine. Isolation has not changed. If you have a positive test, the counsel and guidance is to isolate. So for 10 days since you had a test, without symptoms. If you have symptoms, it's 10 days after symptoms and resolution of your fever with no Tylenol or ibuprofen and symptom improvement. So if you've got a positive test, it's still 10 days. If you have just been exposed, these are changes to the quarantine guidance on the next slide, that you can end your quarantine. You'll remember it was for 14 days. But now if you have been exposed and not tested positive, you can end your quarantine after 10 days without a test. And if you get a test that's negative, you can end your quarantine after 7 days if you have no symptoms. So this, I think, is a positive. This is science leading our strategy for how to manage the disease. So again, if you've been exposed, it's now 10 days without a test in absence of symptoms. And if you've been exposed with a test, it's 7 days. And the test can even happen as early as day 5. So that, now you can get a test at day 5 or 6. And if you get that test within the 2 days before the 7, come out at day 7 in the absence of symptoms with a negative test. Now, why did this change? On the next slide, it's a little bit busy, but let me walk you through it. This is actually science leading us so that we minimize the negative social impacts as much as we can while we safeguard, the transmission threats. These are the number of days, on the bottom left, the number of days for transmission after you are exposed to an individual with COVID-19. And you'll see if you didn't have symptoms, it's the lighter purple. If you did have symptoms, it's the darker purple. You see down about day 10, you start to have relatively minimal transmission. And this is because we've been able to follow people that were quarantined and exposed, and we built the data and the understanding to say, okay, we can bring that 14-day requirement back into day 10. And if you have symptoms, obviously you're a little more likely, so that's why the symptom-free requirement is there. Now, in the upper right, I just want to emphasize, it's not 0. I mean, at day 10, you'll see day 11, day 12, you've still got a little bit of transmission risk at 2 or 3%. So if you've got a family member with one of these comorbid conditions, or if you're in a situation that you think, you may have a heightened risk, I think you still could and should consider 14 days of quarantine. But for most of us, 10 days is enough. and now 7 days with a negative test is adequate. The risk is not zero, but it's diminished and it's small. So after day 10, you'll see in the upper right, the transmission risk is less than 2 or 3%, and it goes down with each day after day 10. So I think those are positive pieces of information. The last slide that I have here is kind of direct guidance from the White House task force. And they basically said if state and local policies don't reflect the seriousness of the situation, then the public health officials must alert the state population directly. And I guess this is where I'm going out. We'll see what Secretary Romero and Governor Hutchinson's message is this afternoon. I do not think to date that they have been direct enough with the public about the risk that's in our community. If all non-essential interactions, I think, need to stop. I think all indoor dining probably needs to stop. I think all bars and entertainment venues probably need to stop. I may be premature on this, but if we're hitting 3,000 new cases a day by the end of this week, then we threaten to go back to where we were when we originally started, overwhelming our healthcare systems and hospitalizations. And this is not about proving that it happened in the bars or the restaurants or the entertainment situations. It's knowing that transmission is happening wherever movement and interaction is occurring. That's in our families, that's in our shopping, that's in our places of business. And it really, I think, behooves us to recognize that we have lost control and not to diminish the potential impact. In talking with those hospital CEOs, I didn't talk to a single one that felt like that we were out of the woods or that it was not likely that we would cross a threshold, that it would be a challenge to provide everyone who needed care the quality of care that we would expect. So sorry for the sobering note. I think we've got some good news on the vaccine front. I think we've got some relaxed news on the quarantine front, but I can't overemphasize the need to protect yourselves and to recognize the transmission path of this virus, and that there's probably not a public place that you go to that the potential for exposure is not real and present. So sorry, Tim, for that sobering Christmas message, but I think it's real. Well,
we're grateful that you have the courage to do it and study it and bring us what you see as the situation, and we're very grateful. So stick with it. It's noble. Is it 5 o'clock somewhere? Does anybody feel like you wish it's 5 o'clock? Can we have questions?
I actually have a question.
All right, Diane.
On that convalescent plasma, what is your, as someone who unfortunately has had this but now recovered, is this something I should look into giving, doing?
Yeah, great question.
Great question. The convalescent plasma is, reserved for use for individuals that are having a severe bout of the disease in the hospital. It is a life-saving treatment for many individuals because none of us have seen this virus before. For those of us who have, successfully had it and recovered, your immune system beat it off. So there's something about the juices in your immune system that were successful with this virus, and you can donate that plasma at your local blood bank. In particular, given the potential threat that I see coming, I would encourage folks to think about it as a unique holiday gift that only you that have been infected can give. I'd encourage you to contact your local blood bank where you would give blood and see what their protocol is for you to be able to donate the plasma, because we may need it in January and February if we have a significant increase in the number of sick hospitalized patients that are dependent upon, basically that is the most successful treatment we have so far because you've recovered.
Yeah.
Great, thanks.
It was the first successful treatment and the best, I guess, still. Yeah. Seemed like it was first, one of the early ones. All right. Other questions?
Joe, Lane Kreider, Beaver Water District. What do you see as what started this fall off the cliff for the United States versus the rest of the world? I mean, what is it that we're doing so wrong
So Wayne, I'm gonna answer your question in a second, but you reminded me of something that I didn't include in this talk that I would recommend for everybody to think about. You'll remember last April or May, where businesses, communities, water districts split their workforce into an A and a B group, so that if the A group went down, you still had a B group available to continue the necessary services. I think it's time to reinstitute that. To actually anticipate a pretty dark January, February, March, and that the impact on workforce is going to be like we've never seen before, because the virus was not as present back in April and May. It is broad spread now. I'm writing a column for Arkansas Business right now, and your question is one that is one of their questions. I will tell you, fundamentally, I think it's a lack of leadership from the top, and it's the fact that this virus hit us in a political year, and it was used as a political weapon to generate self-interested political support. Other countries that have had a unified voice, that have had a not different public health response, some of them have been more aggressive. Other countries have done systematic testing. We see that in our country. Colleges and universities that did mandatory testing every week of all students, whether they were residents or not, have had a 1% infection rate. Colleges and universities that had voluntary testing based upon symptoms, it's been a 10 to 15% infection rate. So it's the seriousness, it's the assertiveness, it's the unified voice that we've had missing in this country, that, it may be that the cow's out of the barn on this and we just have to suffer through it. But I hope that at the individual or the family level, the messages that you all are able to convey, the ones that I'm trying to convey, is that we can safeguard, our families and our loved ones and be a good role model for others, so that they might actually take this as seriously as I think it's going to be.
Mm-hmm. Yeah, well put.
Well, I appreciate that information. We are doing that exact thing that you're referring to, Dr. Joe, and moving our teams of operators, back into a rotation where we are isolating them from everybody else.
Yeah. Last week I made a strong recommendation through the municipal league that all municipalities go back to virtual operations to the extent that they can. Yeah, I think we came into the fall, we hoped it was going to be over, we wanted to get back to normal, and we relaxed a little too much, and we're seeing the impacts now. I think anytime you walk into a closed space and there's one person without a mask, you're at risk. And I think for those with chronic conditions, you'll remember it can be transmitted not only through your nose and your mouth, but also your eyes. And I just think you got to presume the virus is everywhere now. Up until this point, we could hope that it wasn't around us, but right now it is in the public space.
Mm-hmm. Yeah. All right. Thank you. Other questions?
Just a quick question from the new guy. Will we be able to share this with our employees?
What'd you say?
Can we share this with our employees? Will there be a link where we can share this?
Oh, yeah, you bet. Yeah, we'll have it up by tomorrow.
Great. Thank you.
Yeah.
And I would encourage, you or any of your employees, we're putting our newsletter out every Thursday. We're actually going to start later this week doing some regional profiles of the number of, taking what you have in this slide presentation when we're talking about the trauma system and drilling that down for trauma regions, the number of new hospitalizations, number of new deaths. I hope soon to have number of vaccines that have been delivered and number of people that are protected, because that's where we're going to need to move towards.
Yeah, Thursday, and maybe we could, before we get off here, put a link up in the chat. Okay, if you don't mind, Diane, see if you could maybe find that for ACHI's newsletter.
It should be ACHI.net/COVID-19. Michael, maybe you can put that in the chat for us.
That'd be great.
If you would.
All right, Dr. Joe, anything else?
I would come back. I mean, the health department put these numbers out yesterday, and Springdale, Rogers, Bentonville school districts have the largest number of active cases in the personnel and in the students themselves. So, this is a red flag for you in Northwest Arkansas. Y'all are now ahead of Little Rock School District, the Pulaski County School District, the Jonesboro School District. This is I think a red flag warning for you guys up in Northwest Arkansas for younger families. This is not nursing home folks now. These are younger families with school-aged kids.
Yeah. Thank you.
I've got a question, if I could. This is Keith Woodruff, Dr. Joe. I know this is a crystal ball type question, but as you look forward, what date do you think it'll be before everyone in Arkansas who wants to take a virus is able to get one?
Wants to take a vaccine?
Take a
I think we
vaccine.
probably
Vaccine, excuse me, thank you.
That's all right.
The virus, not the
Unfortunately,
virus.
my
the
message
vaccine.
got through to you too much.
Yeah, I'm paranoid
yeah.
now.
My crystal ball, probably no earlier than April, and probably likely by June or July. I mean, I think it's going to be the Moderna vaccine that gets out across the state because of the storage issues. I think the Pfizer vaccine will be used for hospital personnel and nursing home residents and workers where you can actually organize it because of the temperature requirements. But I think the Moderna vaccine and what's happening now is the CDC and Operation Warp Speed, they're allocating vaccine based upon the population and the population at risk. So we're almost in a little bit of a rationing situation now. I wouldn't mind getting a vaccine early on, but I'm not going to be able to because I'm not a frontline adult healthcare worker in the state. So I hope we can generate the demand. I hope the supply ends up, being robust. I think we could potentially, have it fairly widely available by April. I think more likely it'll be by June or July. And I think we could get back to some normal by next fall, but I think we've got another first half of calendar year 21 that's going to be pretty tough.
Yeah.
Thank you.
Sterling?
Yeah, Dr. Joe, every couple of weeks, UAMS releases a report, and they extrapolate when they think that, for instance, in the long term, when the cases will peak. And they've been fairly consistent over the last month or so. We could be as high as 60,000 active infections by the end of March. Do you think that the recent case surge might affect those numbers, where it might be sooner, or do you agree with that characterization?
Well, I think they have been pretty spot on. I'm looking here because I just got their report that they anticipate releasing or have already released. I think they have moved their peak to be 40,000 active infections sometime in the range of late March, early April. I'm going to attempt to share so that y'all can see. This is from their report, again, that will be coming out this week. And I think the thing that is most concerning, so here, they model their data off of real experience. So can y'all see that yet? Let me see.
It's coming. Yes, sir.
Can you see
Almost.
that now? The green is back, before June. The gold is June through September. And the red, and you see the dotted line there that they put on the trajectory, what has happened since October. And so, I think while they are modeling real data, the trajectory here, and this is my cause for the most concern, is that I don't think we know where the peak is going to be now. I think we've lost control of it, and I think we don't know where that peak is going to be. Currently, they're projecting late March, early April. But again, I think a lot of it depends on what, collectively we achieve in terms of control over the next few weeks and how much movement and exposure we have over the holiday season.
Yeah.
And Tim, I apologize, but I've got to bail off
sir.
of you here to get on
it's your time.
call.
Thank you.
Thank you all. Please, everybody, don't hear my message as being, afraid. Let's just be smart. We know how this virus moves. We know what it tries to do. We know how to stop it. And if we all do our part, I think we can. So thank
Well,
you all very
you're-
much.
You're an outstanding healthcare leader and professional. We appreciate you doing what you do.
All right. Thank you. Have a great week and be careful.